it's challenging. We have residents in training with restricted work hours who are having an increasingly difficult time assimilating this information. The sheer data coming from patients today with the sophisticated laboratory, diagnostic, imaging study results available, not to mention the frontiers of genomic medicine, add to increasing challenges as well. So the real question is, how are we going to deal with this as a medical profession, and what is the role of health information technology in facilitating this as well? So let me start you out with a view on this from IBM and IBM Healthcare. And this is a technology conference, but we may be a little technology challenged here. So let's see how we do here.
There are over 12,000 diseases in the world. Some take years to diagnose and treat. How can doctors find insights in a body of medical knowledge that doubles every 5 years? New solutions based on IBM Watson are being developed.
Can't have a technology talk without a little glitches.
Hello, my name is Watson. Let's build a smarter planet.
So, very cool. All the world's literature, all the patient-based data on this particular individual, all being aggregated, analyzing, and coming together to create a top 5 differential diagnosis, of which Lyme disease is at the top, and allow you to move forward without ever picking up a book or going to the library or going to the internet or Google. So the question then becomes, how are we going to get to that point? And what are the steps that we need to take in medicine and healthcare reform and in health information technology to get there? There's a whole lexicon of terms out there now that are challenging to me, so I know they're challenging to you as well, and what they mean and what the implications are for the practice of medicine. Accountable care organizations, meaningful use, medical homes, natural language processing, lots and lots of new terms that show up not only in the lay press, but in legislation and in the medical literature as well. And a lot of these terms have huge underlying concepts that must be mastered as we move forward into the next decade of medical practice if we're going to do this correctly. So I want to talk about today is really the major healthcare challenges that I see ahead of us, and also the role of informatics and health information technology in addressing a lot of these challenges there. So we're going to talk about health information technology adoption and where we are and in comparison to the rest of the world, healthcare reform and what it means to us and the role of health information technology in addressing healthcare reform, how we're going to use technology to improve the quality of care delivery today and in the coming years, what are we going to do in terms of health information technology in terms of optimally engaging our patients in their care, some of these new diagnostic standards, ICD-10, and to follow ICD-11, and then how can we optimize the kinds of decision support and business intelligence, as was seen in the IBM slide there, to allow you to assimilate this knowledge and this data and move forward with the correct diagnostic and decision making. So a little bit about health information technology, and I keep up with this every year, and I always like to show this because it frames our own organization in terms of where we are in terms of adoption as well. So what's striking is that despite all the press and the dollars and the incentives and so forth, only 12% of the 5,299 hospitals in this country have adopted computerized provider order entry as we have here. And even less, 4% have adopted electronic physician documentation. And even less, just a handful are considered paper or electronic hospital paperless hospitals in the United States, a little over 1.5%, and they're actually awarded by a HIMSS Analytics Stage 7 award every year. Now, nursing documentation is a little bit better, with close to 50% of hospitals in this country having had their nurses moving on to electronic documentation there. But we still have a very long way to go to digitize the healthcare information for children in the United States. On the ambulatory side, things are a little bit brighter. In the gray bar there, in the hospital-based facilities or the health system facilities that own ambulatory care centers, close to 50% of those facilities have adopted electronic health records, but the independent practitioners are still sitting down at less than a third in the United States as of the end of 2010 who have adopted electronic health records. We're not doing that well in terms of what the rest of the world is in electronic health records. If you look at New Zealand, if you look at the United Kingdom, if you look at the Netherlands, those countries are nearing 100% adoption of electronic health records, even at the end of 2009 there. So we have quite a ways to go to catch up to the digitization of health information for the patients in our country. Why is it so poor? The primary barrier to this is cost. The cost of electronic health records, whether you're a large multi-hospital organization or whether you're a single solo practitioner, is significant. And there's questions about the technology. We know that the practices that have not been in existence that long, the younger practices, tend to have greater adoption rates. Those practices that are already using technology in some way or shape or form are more likely to adopt technology. But there's a lot of concerns. What value is this going to provide to me in my practice? How am I going to get trained? I don't even know how to type. How am I going to get well trained and feel confident on this? And how much of a hit am I going to have to take in my revenue stream in order to get up to full efficiency or above full efficiency? And then some concerns about the security and the privacy of the data. So that paper chart that I could get my hands on in the office anytime I want goes away and is now replaced by virtual data either on a server or remote hosted in another data center far away. And that concept that my patient's data, those things that I used to write, being somewhere else virtual, is not natural to people who've been in practice for 10, 20, 30 years. So what about healthcare reform? So back in March of 2010, President Obama signed new legislation called the Affordable Care Act, or otherwise known as healthcare reform there. And this is a huge document, and if you're like me, you probably don't know the intimate details of everything in that bill there. But what's in that bill, if it were to be executed, is transforming or transformable in terms of healthcare delivery in this country here. So think about the concepts that are spelled out in that bill there. Insurance for everyone in the United States by 2014. And as a result, a reduction in disproportionate share payments to those hospitals like our own who care for those without insurance. A strong encouragement to develop accountable care organizations that actually account for the care of the whole patient and not just the episodic disease. Shared savings and reduction of waste. Improving quality and reducing costs. You see that over and over and over. The establishment of an innovation center in Medicaid, Medicare, and many of you have seen the grant opportunities of $3 to $30 million that were released recently, with the letter of intent due next week and the grant due in a month there, to retrieve millions of dollars to encourage improved quality and reduce costs. We're not going to pay you for readmissions. We're not going to pay you for healthcare associated or hospital acquired conditions like urinary tract infections and ventilator pneumonias and things like that. Encouraging people to use more generic drugs and for manufacturers to produce more generic drugs, and they protect the intellectual property of them. Encouraging comparative effectiveness research, bundling of care rather than fee-for-service care, more home care, more care coordination. A national quality agenda and strategy. Reducing the disparities in care amongst those who cannot achieve health care in the best of facilities. And encouraging prevention, wellness, and public health. So these are some of the major tenets in the Affordable Care Act from last year, many of which go into play between now and 2014. So if you look at all these things, I've sort of highlighted in red the things that I believe really cannot be performed well without strong health information technology and the digitization of electronic health information, or at least the essential health information for children. Most of these items here cannot be performed effectively, and in some cases the grant opportunities and the funding for this call specifically for health information technology to support some of these endeavors. All right, so how is health information technology helping quality, not only in our own organization, but around the country and around the world there? So, and I sort of want to divide this into sort of what we're doing now and what looks promising on the horizon. So, what are we doing now? So, one of the things that's often said about new technology is that it will ever come into general use, notwithstanding its value, is extremely doubtful. Its beneficial application requires much time and gives a good bit of trouble both to the patient and the practitioner because its hue and character are foreign and opposed to all our habits and associations. So some feel that this is associated with all technology or health information technology, but in fact this was applied to the invention of the stethoscope back in 1834, and this is a quote from the London Times back there as well. So does that apply to health information technology? Are we at the same place that the stethoscope was in 1834? Well, it's not clear. You know, so electronic health record implementation and the literature around the value of that is relatively significant at this point. There are lots and lots of articles in peer-reviewed journal, anecdotal experiences, white papers, and so forth there. And we know that when you implement an electronic health record, you do get some immediate improvement in certain areas of quality. You get rid of transcription of the written order for morphine onto the paper medication administration record and all the errors associated with that. You improve legibility. You make the medical record accessible anywhere in the world. You improve some aspects of patient care efficiency, like medication turnaround times and lab result turnaround time back to the clinician. You bring consistency to the care delivery through the use of order sets and evidence-based medicine there. That's the immediate things when you turn the switch. And then there are the delayed things that are associated with the collection, aggregation, analysis of the data from those electronic health records, looking for opportunities, capturing this data in a complete sense as opposed to anecdotal chart review, and then being able to take that data, turn it around, and disseminate it to those who may best use this in their day-to-day practices. But there are challenges with the quality of electronic health records as well. It's a singular design such that when you make a change in the system, it has the impact on many, many patients there. So if the change that you make is in error, you have the possibility of introducing error amongst a large volume of patients. Picking mistakes, picking the wrong patient out of a long list of patients or the wrong medication out of a long list of medications. Copying forward errors. We see this in our own organization where the note, it's very efficient and easy to move a note from yesterday to today to tomorrow and sign it and not necessarily change anything in it. Downtime. You need electricity, you need wireless, you need networks that are up, you need internet connectivity, and it all has to be in sync and working well for this to work. And as soon as one piece of that circuit goes down, you can lose your access and you're in downtime. Efficiency. So particularly when you first go live with electronic health records, your efficiency is probably going to take a hit, and you're going to take some time to recover from that. And that may be anywhere from 6 weeks to 6 months, depending on the quality of the application, your education, your support, the performance of the system, and so forth there. And then communication. Physicians doing things in the electronic health record without that old-time voice communication back to the nurse or the respiratory therapist with the assumption that what I put in the electronic health record is seen by everyone. That can be an issue as well. Clearly, in certain areas, we've made some great strides. Medication safety is one of them. We've all prescribed on paper in the past the illegible order, the unapproved abbreviations, the leading and trailing zeros, the illegible signature, the pharmacist calling you all day long to clarify your orders. Most of that has gone away and been replaced by a complete legible order. And as far back as 14 years ago, David Bates and his group at Brigham and Women's was able to publish the first article showing that when you implement CPOE, you do reduce medication errors in a large hospital setting there. We know from 8 years ago, the first article in Pediatrics showing that when you put CPOE in a pediatric institution, you can decrease medication error rates as well. And as of an article from last year from Renu Kishal showing that e-prescribing, electronic prescribing in an ambulatory setting significantly improves the safety of medication prescribing as well. So those are fairly clear-cut, almost immediate gains with the implementation of electronic health records here. Here's some data from Cincinnati Children's where we've tried to look at what happened with mortality rates in the organization after CPOE went in place. And this followed some work from Pittsburgh Children's which suggested that CPOE actually increased mortality rates. We didn't see that in Cincinnati, and we also did not see that at Lucille Packard last year when they published their work showing the implementation of CPOE and no obvious relationship with mortality other than perhaps a reduction in mortality after CPOE. The illegible note being replaced by the legible note there, a clear benefit, legibility improves there, but not necessarily a clear benefit all around there. So yes, we get a complete note, we can auto-populate data, it's legible, it's accessible anywhere, we can put coded diagnoses, we can search on the note, and we can bill off of that note. But there are issues with it. Is it more efficient or less efficient? The copy forward issue that we mentioned before. Too much clutter, a lot of gibberish in the note that was carried forward, dates and times, 6-digit times. The quality of the note, is it readable? How well does the note communicate the issues going on with that patient? A lot of these issues are actually being looked at actively by Paul Manicone in our own organization and others as well. And then how does that note allow us to respond to the demand to move to ICD-10 in October of 2013? We'll talk a little bit more about that in a little bit. So what about engaging patients and families, and what's the role of health information technology in that particular issue there? And I want to try to go quickly through the issues of around electronic copies of patient records and making those available to patients, patient portals where a patient can log on through their smartphone or their iPad or their home computer and engage in their healthcare delivery system, patient health records, patient scorecards, and a little bit about telemedicine there. So this is a patient portal that we implemented last month in our Goldberg Center for Primary Care Pediatrics there. It's in a test environment. It's not actually turned on yet, but this is accessible via the web in a secure manner. It's private, and it allows the patient to go over and see some reminders, to ask their doctor a question, ask for a medication refill, request an appointment refill, download education. We even throw a little bit of advertising at them. Actually, the vendor does this, appropriate advertising. It's an interesting model, but the advertising allows the vendor to offer this free to the organization and to the patient there. So they don't actually charge us for this patient portal if we agree to allow advertising and actually sit on their board to help them decide not to put cigarette ads and other things like that there. So that's an example of a patient portal. It's actually activated in our primary care clinic, and many of our community practices in the D.C. area who've gone up on electronic health records use patient portals. And just a quick show of hands, how many of you interact with a primary care physician who has a patient portal right now? So maybe about 20%. And I think if we asked this question a few years ago, the answer would be 0. Personal health records are the movement of the data from the electronic health record into the patient's record that they can then augment with their family history or a medication that they picked up in Los Angeles or what have you. and being able to access this anywhere so that you have a firm understanding of your health-related issues there. We know from several studies that up to 60% of patients presenting to an ambulatory surgery center do not know the complete list of medications they're on, or that their patient or their family member is on there. This starts to address some of those issues and provide some place for a person to get their information there. And then individual patient scorecards. This is a real scorecard from Denver Health in an adult patient who has a chronic condition, hypertension in this case there. This is handed to the patient and also provided electronically on their patient portal so that they know what medications they're on. They have sort of a green, yellow, red dashboard about how well their blood pressure is controlled. It gives their actual last blood pressure medicines there. So you can sort of start to see how you as a practitioner of a patient with a chronic disease may be able to leave the office with a printed or electronic copy of their health scorecard and how they're doing there. Teleconsultation. So we conducted some work last year down in the Northern Virginia Regional Outpatient Center. Dr. Kogan and Dr. Pearl saw patients, but they weren't there. They actually were here. The patients checked in, registered, got their vital signs, and were put into a room with a relatively inexpensive computer and video camera and conducted a follow-up visit, multiple follow-up visits on their patients there. And this was a significant step forward for patients and their satisfaction as well as our consultants. We did some user satisfaction surveys with that and found that in the areas of how well did you like access to the system, how well did you like the visit, during the visit, and overall, and on a 1 to 5 scale, you can see that the ratings of these 7 patients in this pilot were all close to 5 on the impact of a teleconsultation visit like this. So thinking about patient engagement in multiple different ways and where we're going with this is not 10 years from now. This is not even next year. These are things that we are doing now that will facilitate patient engagement. So what about this whole ICD-9 to ICD-10? What's this all about and why are we doing this? Well, there's a lot of different reasons. It's primarily driven from our payer-based systems. But ICD-9 is actually out of room. There are no more codes to keep up with the expanding list of medical diagnoses there. And so one of the major rationales to go to ICD-10 is expand the number of codes there. But it's also a framework which will allow the medical establishment to do better analysis of disease patterns and treatment outcomes and to allow us to streamline some of the way we submit claims there. This is going to have a significant impact on you as a provider in the documentation that you provide there. And it's going to be quite challenging for our organization and others, and we're working closely with consultants and vendors and so forth to ease this transition there. Essentially, if you haven't read much about this, it's moving from ICD-9 to ICD-10, moves you from a 5-digit to a 7-digit code. So practically speaking, the old closed clavicle fracture ICD-9 code of 810.0 gets replaced by a 7-digit code that includes things like the laterality of it. Is it a right or left clavicle fracture? And then the encounter level. And then depending on the disorder that you're coding, for example, a laceration, it may have the depth of the laceration. If it's otitis media, it will say whether it's suppurative or non-suppurative, and if it's perforated or non-perforated. So it adds dimensions to the code such that you can get more specificity of what actually is going on with that patient there. But the real bottom line for us from a financial point of view is if we submit claims on October 1st of 2013 with ICD-9, they're going to be denied because they're looking for ICD-10 codes there. So we have to figure out a way to get our provider documentation up to par to be able to meet these needs there. And that's not easy. So for clavicular fracture, for example, if you search that in an ICD-9 lookup table, you may pick up 10 or 12 ICD-9 codes there. And if you do that in ICD-10, you may find 7 pages of clavicular fracture codes there. And the idea that you as a clinician will waste your time going through these long lists trying to find the appropriate one is just sort of ludicrous. So we're working with our vendors now with these kinds of designs that we believe we'll have available when we go live, so that you type in wrist fracture in this search term over here, and then it's smart. It asks you questions that you can quickly click through. Is it left or right? Which bone are we talking about on the wrist? Is it displaced or not? Is this acute or chronic? Is it a closed one? And so by quickly clicking through a few radio buttons there, it'll spit out that bottom diagnosis of an ICD-10 code and then have that interface into a billing system there to make your life a little bit easier. So this is where we're going with that. All right, so what about decision support and business intelligence? And if you go back to that first video where the clinician is standing there and the data is being harvested from the world and from the patient, and it's spitting out a differential diagnosis there. How are we going to get there? So we do business intelligence now. We do decision support now, but it's what I would call primitive in its manner. So you're all familiar, those of you who use Tracks are familiar with the decision support that's built into the system. Now, some of this came from the vendor, some we built, but when you order a drug like potassium, for example, you can click directly into the formulary and see what the indications and contraindications of the drug are. You can display the patient's medication dosing weight. You can see the last potassium values, or you can graph it. And if you make a mistake and you overdose, and it happens to be one of the drugs that we do dose range checking on, then you can get alerted. But these are very primitive in my mind. They're very error prone. You can override the alert. You can order potassium in the absence of having a recent level on the potassium. We know that people don't often utilize this decision support because they're busy. They want to give the potassium to the patient and they don't want to be diverted somewhere else to read, things like this. So yes, it's integrated into the workflow, but it's not necessarily where we want to be. Similarly with order sets, we try to build evidence-based medicine and consistency into the order sets for the diseases that we use to take care of patients here. So if you are admitting an acute asthma exacerbation patient, you can open up the acute asthma exacerbation order set, and you can utilize a decision support system that includes evidence-based orders for that child there. But yet, if you look around our organization, many children are admitted with order sets that are called general admission order set or PICU admission order set there. They're very non-disease specific entities, and yet they give some consistency, for example, around how often are we going to get vital signs or laboratory studies and so forth, but they're not necessarily disease-specific order sets, and that's really where we need to go. We try to aggregate data, so rather than having you click on a lab tab and click on a medication tab and an allergy tab, try to bring it all together in one place, and we're just sort of stepping into this in our own organization, and others are as well, where you can aggregate the important information for you in taking care of this patient. So this may work great if you're an ICU doctor, but maybe the rheumatologist doesn't want to see that. So we're very generic in the way we provide this decision support, and we need to get better about providing this on a very specific specialty by specialty or provider by provider basis. So what about business intelligence? What's the difference between business intelligence and decision support? I think we're all fairly familiar with business intelligence as it applies to finance. We've been doing well with business intelligence for many years here in understanding the inflow and outflow of cash into the organization there. But this is business intelligence as it applies to clinical care delivery there. So, and I like this definition because it talks about workflow integrated information that enables you to drill down from reports into a detailed analysis of quality, safety, the things that you care about. So what are the key words here? It's workflow integrated. In other words, you don't have to go to the library or to another application on your computer or to the chain down formulary in the nurse's station or whatever to get your support, but it's right there in your workflow. It's enabling. It has drill down capability so that it gets you the ability to drill down to something that's meaningful to you as a provider. It addresses the issues of concern, and it offers opportunities for improvement and places for you to set your sights on in how to provide better care. So we do some of this already. They're relatively static. We've got a financial dashboard. We have a patient satisfaction dashboard. We've got a quality dashboard. And we even put in there on a daily basis an update of the number of days since our last serious event. How many of you use these dashboards on a daily basis? If I could see a show of hands here. So about 6 people. Why is that? Well, one thing is it's not integrated into your workflow. You got to go to the intranet and then you have to sort of navigate a little bit there, and you're busy and you don't have time to do that. But probably more important is that when you're asking the question as a resident or a nurse or a faculty member, how am I going to impact patient satisfaction or mortality rates or days since the last appointment there, you may not necessarily know how you as an individual can impact these metrics there, because there's not a lot of drill down capability to sort of go down and see where that makes a difference there. So I want to give you a few examples, and apologies to David and others who saw this the other day, but some examples of how workflow integrated business intelligence may affect you in the future there. So these are sort of semi-hypothetical cases. There is some real data in here as well. So distraught nurse, it's 3 a.m. She's at the end of her shift reporting to her nursing manager saying, you know, last night at 3 a.m. Dr. Hofster gave me a verbal order for 20 milligrams of IV morphine. Right after I gave it, the child stopped breathing and had to go to the ICU. We had a code. And later on, he told me, I said 2 milligrams, not 20. And she says, I know what I heard. So what's the nurse manager to do with this today? Well, generally in all these cases, a meeting is called. And people get around the table and discuss the issue and come up with some kind of determination about what happened, how to remediate it, and how to prevent it from happening in the future. That's sort of the way we do business today. So how might this look in a business intelligence environment there? Well, this nurse manager may go to their desktop and say, I'm going to look at what's going on with verbal orders in this organization. And this is actually real data from our organization there. And then she says, all right, well, this happened on November 13th. I'm going to look at that, and I see the top 10 people in the organization who give verbal orders. And look who's number 1 on the list there. So she has intelligence now about this particular example that you don't get in a meeting, in a consensus meeting or anecdotal discussion there. So then the issue becomes, okay, what are we going to do about this? Well, I suggest that we run weekly reports, that we give feedback to the top 10 people on this list every week, and that this particular doctor, we need to do some individual counseling, and we need to support the nurse, of course. So example number 2, a couple of well-known figureheads in the organization. One of them looking at the dashboard and seeing a huge spike in mortality for this month there, and turning to our director of patient safety and saying, you know, look, this is unacceptable. What's going on here? Well, fortunately, this director of patient safety has a dashboard in his workflow who can say, all right, I want to drill down on that point right there. And I see, looks like it's not involving the NICU or the PICU or the cardiac ICU, but there's a big spike in mortality for that month in hem-onc. And furthermore, I want to drill down on that point there and see who were the patients who died and what were their diagnoses and who was their attending. And there's a pattern that shows up over here. And an action plan is created, and now business intelligence has been used to help in the workflow, and now we've got a happy CEO. Last example here. One of our famous researchers in the organization has a great new weight loss drug that has been shown to be very promising in rats. There's some good safety data in adults there, and he wants to do a study in children because he thinks this would be great for our 31% obesity problem in the D.C. metro area there, but doesn't know how to go forward with this because it doesn't have the data there. So the head of the Obesity Institute or the co-director of the Obesity Institute says, well, we happen to have data harvested from the electronic health records in my workflow on my dashboard, and I know that when we geospatially map obesity in this region, we have hot spots in a lot of different places, and the action plan then becomes, okay, we're going to use this business intelligence to consider a study of this drug in Ward 7 in the DC area here. So I try to sort of drill this down, so to speak, to something that makes sense to you. Everyone in this room should have workflow integrated business intelligence that is meaningful to you and easily available so that you can do your job better there. And that's where we need to go, and that's where we are going. So here's my desktop, typical desktop. I've got the kids there. I've got internet access, and I can sign off on my time cards, and I can go to tracks, and I can do a Word document there. But you can see there's no dashboard. There's no integrated workflow dashboard there. So what I think where we need to go as practitioners is the aggregation and analysis of the data that's important for you and displaying it prominently on your dashboard. So if I'm an emergency room physician, I can easily see what's going on with our triage to doc times and our ED throughput and where are we having problems, what day of the week, what time of day, and adjust my impact accordingly. Now, I throw this up here. This is an architecture map from Centera in Norfolk, it's a place where they do really good business intelligence. It's probably one of the few good organizations in the country that are doing this. And I throw this up here because it's not easy to do this work here, and it's a bit complicated. So what does it involve? It involves taking a look at your information systems within your organization. So most organizations have in the neighborhood of 100 to 200 information systems. Laboratory radiology, demographics, pathology, GI, cardiology, where health data is stored there, and it's very inaccessible. It's very difficult for the average user of those systems to get any information out of those systems, let alone get aggregated information across systems there. So in order to do this correctly in a classic way, it needs to be, you need to assemble a data warehouse. It needs to be enterprise-wide. So it requires talented people to understand the information systems, to be able to identify the data that they need, extract it, transform it, load it into a warehouse, ensure the quality of it, and then partition it into small data marts. So maybe you have an infection data mart or a surgical data mart or a case management data mart, a place where the relevant data for that particular area is stored. And most importantly, creating the workflow integrated tools for you to receive general, regular, aggregated reports, but also to be able to do ad hoc reporting and ask and answer questions of that data within that data mart to allow you to do your job better. It's not an easy thing to do. We've launched into this a bit this last year and have a prototype in place, but it does require ongoing work, and it really never goes away because you're constantly refreshing it with new health data, maybe genomic data down the line, financial data, administrative data, and so forth. All right, I want to try to show you a video here if I can get this to work. It's another IBM video, not to tout IBM, but they've invested a lot of money in making these videos. And I think the videos are good in that they allow you to sort of think out of the box and think visionarily. And they call this medical record text analytics solutions. So let's see if I can get this to go to the right place here. Okay, so they're going to talk about a patient that presents to an emergency room.
Care and patient outcomes. Let's take a look at one patient's story and how a health plan handles his high-value claim. John Smith arrives in the emergency department with a complaint of chest pain, shortness of breath, and pain in the left arm. By the end of John's treatment, he has spent 7 days in 2 different hospitals. His claim is valued at over $100,000, so it moves for evaluation. The health plan requests information from both hospitals. The first hospital sends an HL7 electronic transmission of documents.
The electronic health record hospital.
While the second hospital faxes documents.
Paper hospital.
Altogether, the health plan receives 50-plus pages on John Smith. IBM Medical Record Text Analytics Solution, MARTIS, pulls the 50-plus pages into the system, classifies documents into categories, and converts faxed images and PDFs into text. MARTIS begins to identify the key data and populates the medical findings in a structured format into a database and assigns oncology codes to them. John was examined by an emergency physician. John's EKG was normal, but he had classic symptoms of acute coronary syndrome and responded to nitroglycerin, so a cardiologist was consulted. The emergency physician also called an internist to admit John overnight for observation. A nuclear stress test was performed on John the following morning. The results revealed critical blockages of coronary arteries. The cardiologist recommended an angiogram be performed ASAP. Within an hour, John was prepped and the angiogram performed. Because of how many arteries were blocked and the locations of the blockages, John was not a good candidate for stent placement. John was transferred to another hospital for cardiothoracic surgery consultation. The next day, John had bypass surgery. John stayed in the second hospital for 5 days, where he developed a urinary tract infection. He is discharged to a rehab facility. Now that the data is in a structured format, it is ready for analysis. The data can be used to enhance a 360-degree view of John's care. A medical examiner can use this dashboard to review findings extracted from John's medical record and alerts generated from deviations from standard of care. The dashboard can also link back to the original medical record for further details. The dashboard enables medical examiners to find information and resolve claims quickly. It also empowers the health plan to provide better services, such as offering appropriate disease management counseling or identifying additional products and services. The data can also be used to run a report, using a rules engine to identify deviations from standard of care. EKG done 20 minutes after arrival when the standard is 10. Urinary tract infection during hospital stay. Beta blocker is not prescribed at discharge or administered in the second hospital. The care representative contacts the provider to verify the deviations and then contacts the primary care provider to develop a corrective plan to ensure protocols such as prescription of beta blocker are performed. The health plan can also use these figures to evaluate providers on their performance and potentially adjust claims reimbursement rate to encourage higher quality of care. The IBM medical record.
Okay, so we'll stop there because it goes on for a couple more minutes there, but a clear pediatric example, obviously, there. And the orientation, obviously, is toward the health insurer and the payer and the reimbursement issue there, but you can clearly see how this would have great applicability to you as a provider, you as a safety officer, you as a quality of care delivery person, or even you as a researcher as well. And I show this because although it seems rather distant in the future, it's not that far off. And in fact, in our own organization, we're starting to do some of this already. So a lot of the basis of what you're seeing in that video is around natural language processing, which is basically analyzing the human language so that it's compatible with computer language there. And that's not as easy as it seems. It's about 20, 25 years old already, but it becomes challenging. So take this very simple example of baby swallows fly. Depending on whether swallows or fly is the verb, or swallows or fly is the noun there, you can have drastically different interpretations of this data there. So to simply say, use an NLP engine and make the machine tell you what's going wrong with the patient there has challenges with it as well. But over the last 20 years, a lot of this has gotten better there. For those of you who use tracks, you know that we recently implemented natural language processing in our own electronic health record here in something that's called chart search. And what chart search does is it allows you to go to an individual patient, and this is a real patient here, and search the term sodium, for example, and then have it return everything in this patient's medical record, not just this inpatient visit, but anything in the visit related to sodium, including the values, the notes there. You can see a note by Dr. Spader from the ICU that had something in reference to sodium in this patient there. And it's Boolean in nature, so you can add other terms, sodium and hypoglycemia and Spader, or not Stockwell, or whatever you want to do to try to go through that patient's chart there. The next frontier after this is to be able to start to do searching across your organization there. So if you're interested in juvenile rheumatoid arthritis, to do the same sort of chart search across patients there. There's obvious issues there around privacy and security and the need to do that in a de-identified manner stripped of protected health information is going to be important, but that is not too far away right here in our own organization for the care delivery person, the safety officer, the quality improvement person, the case manager, the clinician who does research, or even the basic science research trying to move something in the clinical space and generate hypotheses. So let me try to summarize today's talk there, and then we'll have a little time for questions in the end here. So what I would say is that digital health data within the electronic health record is really critical in what we're trying to do in healthcare reform. It forms the basis for a lot of the tenets of the Affordable Care Act, not simply from a legislative point of view, but from where we really want to go in terms of the care that we deliver to our patients. That the implementation and the optimal use of the electronic health record can significantly improve quality care delivery. We're not quite there yet, in my mind, but I think we're heading in the right direction. We now have a rich data source in our electronic health records, both in the inpatient environment, the ambulatory environment, and in health information exchanges to look at care delivery improvement opportunities, quality, safety, and effectiveness opportunities, and to be able to support the research that we want to do in looking for hypothesis-generating studies and ask and answer questions. And that, most importantly, in getting back to these two videos, that decision support and business intelligence using natural language processing and other tools is really where we need to go. As I started the talk saying that, you know, it's become very challenging to work in medicine these days. And most of the challenge relates to the data in the literature, the data in the lay press, the data coming from the patient. We've got to get a handle on this, and one way to do this is with better decision support and better business intelligence based on the data that we have available. So let me stop there, and happy to take any questions, and thank you for your time. Please, if you have any questions, if you can come up to the microphone. If you press the bottom, it should turn on.
I'm challenged here. How do you think the electronic health record and all these advances will go towards reducing healthcare disparities? Because at least on the surface, it seems to me that this might just increase healthcare disparities because of access issues and stuff like that.
That's a great question. I think one of the main advantages in the electronic health record is just simply the ability to detect and recognize where those disparities exist. We've done some work preliminarily here around obesity, for example, and you know, we have an obesity institute. We have some very talented prevention and treatment researchers. We have a national imperative around treating it, and yet we didn't have a firm understanding of where obesity exists in our environment, where those disparities of care are. And similar to the work that we're doing with asthma and trying to figure out, you know, who is actually presenting to our emergency department with asthma. Is it a particular environment, a particular socioeconomic class? How do we best target our efforts there? So I think recognizing where those disparities exist and what are the covariables associated with it. Is it pollution? Is it McDonald's? Is it whatever? Allows you to start to address them a little bit better because you're better informed about the nature of those disparities and then help you start to target them better.
Sure. Thank you. I recently met with our family advisory board of the PICU, and they are clearly much more tech savvy than I. One of the things that they asked is that at the end of our family-centered rounds, we create a summary statement about the care plan for the day. And they asked how far away are we from converting that information to more patient and family-friendly information using natural language processes.
That's a great question, and I think it speaks to the whole issue of patient engagement here. we have to move away rapidly from the patient that is not engaged with their care or the family that's not engaged with the care. It's just not something we want to do in the future. We've got to move forward with that as well. So the health information technology that we have available today has the capability of doing this. So in the process of taking the time to generate a note, progress note, discharge note, admission history and physical, there's really no reason why the essential data that's important to that family can't be extracted from that and populate a letter or a summary or so forth that could then be presented to the patient in a printed format or in their personal health record or on a portal and so forth. So I would say that that is an essential feature for care. It's coming, and it's something that we have to do to better engage our patients. And when we do that, we're going to see the quality of their care delivery improve, the compliance with the things that they need to do when they go home, and satisfaction will go up because the family and the patient are more engaged in their care delivery.
Thanks, Brian. Thanks for these updates because I think these are very important, helpful in knowing exactly what's going on with our move towards being paperless. Having said that, most of us who are housed in the outpatient services are still in the dark ages. So we just recently, Susan sent out a survey where we carry charts from here to satellite clinics and have those who have asked about creating some kind of web page that's housed within the divisions are not able to do so. We're waiting for the system to generate or at least become available in all the subspecialties. I say we're in the dark ages because the physicians who make the referrals are also very frustrated by the fact that they have to wait for letters that are generated by dictations and are not able to care for the patients as we recommend because they get all these information from the inpatient services, but they cannot relate that. There's no translation to the outpatient care. How long is that going to take, and can we individualize these services so that each division can actually generate their own?
Thank you. Great question. I would agree with you that we are in the dark ages in the specialty clinics in this organization. I would also point out that most specialty clinics in this country are in the dark ages as well with some of the similar challenges that we have. But I do believe there's light at the end of the tunnel here. We've made a couple of significant steps in the right direction over the last several years there. So first of all, the dictations that you do actually go multiple places. They do arrive back into the electronic health record, the TRACS record there, and are consolidated with all the inpatient records there and are available and accessible wherever you want to access them as a provider here. We've also moved those documents into a community physician portal that have over 1,050 providers in the area signed up, so they can go into that portal in a secure and private way and look at the consultant visit notes from the clinic that you've dictated and get that information back there. The communication methodologies with community providers are not perfect. They've improved a little bit over the years, but we have a ways to go as well. But the key ingredient with moving us to where we need to go is getting an electronic health record in the specialty clinics there. And that electronic health record needs to be integrated with what goes on in lab, radiology, the inpatient, the emergency department, and so forth. And I think once we make that step and implement that and get people using that at a relatively expert level there, engage patients with patient portals with that data flowing out there, it's going to change the ballgame altogether. So we're going in the right direction. I think we're looking at sort of an 18-month time frame to get to that point. There's some significant organizational investment that's required, but we've got to do it, and I think that's the direction that we're heading. Hi.
Question for you. I'm going to generalize it first. Noticing the younger generations today in the general population with access to technology and increasing availability of the technology, we're kind of losing the human factor because we're not communicating anymore. Everybody's on the phone texting, And we're, by going to the electronic processing, do you feel that we're going to be losing the human factor with our communication amongst our healthcare providers?
Yeah, I think that's a commonly held concern, that when you start to replace human-to-human interaction with machine-human interaction, that you lose some of the art and the interaction that we so cherish, and why many of us went into healthcare delivery as well. I think there's many ways to overcome this. So, and you see this every day when you walk into a bank, for example, so that the teller that hides behind the computer and has no eye contact with you and does a financial transaction is very different than the one that steps over to the side and interacts with you and the computer at the same time. Or if you go to Enterprise and you rent a car today, it's not like the old days where they're standing behind a computer, it's a green screen, and there's no eye contact because it's all about data entry there. They actually will step to the side, will come up around behind the counter, and actually escort you to your rental car there. It's that human element that is so important, and we can't forget that. And I tell this to the residents all the time, that you cannot put an order for care, especially critical care or essential care, into a computer and expect that that's going to be carried out the way you meant to be carried out. There is no substitute for oral communication of important things, and I don't think we can lose track of that. The goal here with the technology is to provide you more efficiency, more information, and hopefully free up some of your time. So in the critical care environment, a great example is our nurses used to use big paper flow sheets and a pencil and chart systolic, diastolic, respiratory rate, pulse oximetry every single hour. And at the end of the day, they would take a hand calculator out and add up all the I's and O's and everything else there with a significant error rate, I would say. So all of that is now replaced by the automated flow of data from monitors and ventilators and auto calculations as well. And it's a pretty cool thing that most of the nurses who are new actually don't even realize. If you've been here for 10 years and you went from that environment to now, you know that you've now become more efficient in that particular process, and you've freed up some time that you can actually spend with your patient or talking over care delivery with your care team and so forth. So it's a really important point, and I think we can't lose track of that human interaction that is so important. It can't be replaced by a human-computer interaction without those essential points being communicated orally.
Okay. Well, piggybacking on your point of efficiency, the U.S. is primarily run by, we would like to say, our physicians and our nurses and our healthcare providers. However, insurances, pharmaceutical drug companies, and everything come into play, especially when it comes to our reimbursements, especially when it comes to payments. And as we move to the electronic documentation and we're moving to a more efficient way of providing healthcare to our patients, are we going to be encouraged to see more patients and therefore lose some of that efficiency in a way and miss diagnoses and miss care that we should be providing that should be better quality care?
That's a great question, and I'm not sure I know the answer to that. I think there are ways to provide higher quality care in the same period of time. We need to capitalize on those methods. I think there are ways to provide care like the telemedicine example that we gave you that becomes more efficient for the patient and more efficient for the consultant, and may actually allow them to see more patients during the day and not necessarily stay longer or use more time there. But a lot of that remains to be seen how this is all going to fall out in the end.
Well, thank you.
So with that, I know we're a little over time here, so why don't we finish up there, and thank you so much for your attention this morning.